This lecture for Nursing 224 is going to look at cardiac disorders with clients in situations where patients have cardiac needs. The first lecture we're going to cover is going to look more at assessment and diagnosis of a patient that has cardiac disorders. Then the second lecture we're going to go through a case study that will apply all that information. The third lecture is actually going to take you through a lot of different cardiac disorders such as CHF, hypertension, deep vein thrombosis, arterial disorders, and then the last thing that will be covered will be EKG recognition and interpretation. When we look at nursing situations for clients with cardiac needs, cardiovascular disease is one of the top problems in the United States. It causes about 1 million deaths per year in the U.S., and overall it causes probably 42% of all total deaths, and it actually kills more people than cancer, accidents, diabetes, the flu, pneumonia combined. So with it being the #1 killer in the United States, some other statistics that are kind of interesting is that it's found that probably 50 to 70% of early mortality in the United States is due to lifestyle factors. So if you think of smoking, obesity, decreased exercise, and all those kinds of things, those are definitely things that factor into clients that have cardiovascular disorders and put them at higher risk. The classic symptoms that are seen with heart disease include dyspnea, chest pain or discomfort, edema, syncope, palpitations, and fatigue. Heart disease is more common in men than women until women get to be of postmenopausal age, and then those statistics start to even out a little bit more. This shows a chest x-ray of a client that is part of the diagnostic area of a client that may be suspected of having heart disease. The chest x-ray can give a lot of good information about the heart, such as the silhouette of the heart, if the patient has pulmonary congestion along with heart problems and enlargement, and if that patient has catheters in, such as a Swan-Ganz catheter or different things like that, it can show the placement of those catheters and if they're in the correct placement. Patients with heart disease will have typically an EKG performed as part of their initial assessment, and a 12-lead EKG, which all of you have probably seen done on your patients at this point, is used to identify areas of injury, ischemia, infarction, hypertrophy, which is an enlarged heart, conduction problems within the heart or heart defects themselves, can help to determine pericarditis, dysrhythmias that the client may have. So it can give a lot of useful information, and it's a very non-invasive test. Obviously, it's not painful for the patient, and it can be interpreted rather quickly in an emergency type of situation. So patients that have 12-lead EKGs or those types of things do have some restrictions. Obviously, the patches need to stay in the position that they were put on and those types of things. And if the patient is on a telemetry unit, such as what we're going to describe on this slide, the patient can't take shower or tub baths, obviously, with the telemetry leads on, so the patient needs to be disconnected for those. And nurses that are on telemetry units need to know what the alarms mean if the patient does have an alarm that goes off. Is it because the patient had an arrhythmia? Is it because the patient just has a loose lead? So the nurse needs to know, or is it just because the battery's low on the telemetry unit and those types of things. Telemetry EKGs, which most of you have probably seen by now, these are usually on most all step-down units and some regular med-surg floors. It provides a one-lead continuous view of the heart's electrical activity. So usually you're going to see just 3 to 5 electrodes placed on the patient's chest for telemetry readings and those types of things. And then the patient a lot of times just wears a portable unit around their neck, maybe hooks into a pocket on their patient gown, and then the transmission is sent to a universal spot, whether that be that particular nurse's station, or some hospitals actually have all telemetry patients the transmission is sent to a central floor where that's all nurses do is look at telemetry and interpret any problems that there may be for all patients on telemetry in that particular hospital. Holter monitors are portable and continuous monitors that the patient would have. These can help to identify cardiac function or arrhythmias a patient may be experiencing. A good example of a Holter monitor is, think of a client that perhaps is having runs of abnormal heartbeats. They feel like they're having skipped heartbeats, or they're having episodes where they're having accelerated heart rates. They feel like their heart's just racing, or different things like this. The cardiologist may order a Holter monitor for that patient, where the patient wears actually an ambulatory type of a monitor, as you see in the picture, for 24 hours. And the patient also keeps a logbook then and writes down any time they have signs and symptoms of their heart problem, or if they're exercising or doing things that would be putting stress on the heart. And then what happens is there's a download that the cardiologist can get from this Holter monitor, and then the cardiologist can compare symptoms that the patient had time-wise versus what pattern and arrhythmia that was noted on the Holter monitor's download tracing. So the patient would have to be taught they can't take tub or showers during this particular 24-hour period, and to make sure that they're keeping the log going to let them know when they're experiencing chest pain or funny feelings in the chest and those kinds of things. Patients suspected of having cardiac disease will also have exercise stress testing perhaps ordered. And if you think of the reason for this, normally if we would exercise, our coronary arteries can dilate up to 4 times their usual diameter, and as a response to increased exercise or stress on the heart or those types of things, so that the heart can accommodate for that increased metabolic demand. Patients that suffer from heart disease, however, and atherosclerosis, because of the plaque formation and the narrowing that's within the coronary arteries, the patient's coronary arteries are not able to expand in diameter as normal ones would. So when that patient's heart is stressed, that patient develops chest pain, angina, shortness of breath, and different symptoms like that. So the exercise stress testing will actually try to stress the heart on purpose to see if that patient does have any abnormal signs and symptoms while the heart's under stress. So typically the one that we probably see used the most are patients put on a treadmill. And then what happens is the treadmill is gradually inclined. Usually about every 3 minutes the treadmill is inclined for about 15 more minutes, so that it increases the workload on the heart. While the patient is having this done, if you look at the picture down in the left-hand corner, the patient's EKG, vital signs, signs and symptoms of how they're feeling, and all those kinds of things will be recorded and monitored to see if the patient's having any adverse effects to the stress test. If the patient starts to develop adverse effects such as chest pain, serious arrhythmias on their EKG, premature ventricular contractions, hypotension, dizziness and vertigo, significant ST depression, or all those types of things, then the exercise testing would need to be stopped, and that patient would need to have a further workup. The scanning that's listed there, the thallium or cardiolite scanning and imaging, are actually radioisotopes that are injected intravenously while the patient's having this done. And then what they're going to be doing is, as you can see in the picture down at the bottom right-hand corner, they're going to be scanned after the test to look at the uptake of those radioisotopes by the cardiac muscle, and to see how everything looks on that. So the scan takes about 2 to 3 hours while the heart's at rest, so that they can look at problems that may be going on with the heart. But what about those patients that are not able to tolerate actually maybe getting on a stress test or getting on a bicycle or things like that due to some medical condition? These patients can actually be given medications that will increase the stress and the workload on the heart as if they are exercising. So one example of such a medication is called persantine, and this is also known as dipyridamole. And this is a medication given IV, and it will mimic as if the heart is being stressed, or as if the patient would be exercising, and that type of a thing. So the patients still need to report if they start having symptoms of chest pain, shortness of breath, those types of things, headaches, dyspnea, facial flushing, and all those kinds of things, so that the patient could be monitored appropriately. Another type of medication would be adenosine or adenocard. This one has a pretty short half-life, only about 2 to 10 seconds, so it wears off rather quickly. And the third one that's listed there is dobutamine, and this also will increase myocardial contractility, heart rate, and blood pressure, which will increase coronary oxygen consumption and those types of things. Dobutamine is a good type of a medication if the patient has bronchospasm and pulmonary disease, and who can't tolerate maybe having their theophylline, which is a bronchodilator, being held. Certain medications need to be held before these tests, and some patients just can't tolerate some of their bronchial medications being held. So in that case, they may have to use dobutamine versus persantine on those particular patients. So nursing care for patients having stress tests, they need to rest prior to the exam. They need to be NPO or at least have a very light breakfast if their stress test is a little bit later in the morning. They should wear comfortable shoes and clothes if they are going to be placed on a treadmill for their stress test. And they're supposed to avoid caffeinated beverages, alcohol, and smoking on the day of the test, as well as taking any nitroglycerin that they may have been ordered for 2 hours. Because when they stress the test, they want to see a true reaction of what happens with the patient's signs and symptoms, and they don't want it to be masked if the patient has had nitroglycerin, which actually will help to decrease chest pain. So the physician will give them a list of what they need to make sure that they are not taking and those kinds of things. A lot of times they're also told to hold their beta blockers, calcium channel blockers, ACE inhibitors for up to 36 hours before the test. But they are given a strict list of what they are to take or not take and those types of things. So just remember that your beta blockers would be your drugs that end in OL. So that would be, for example, like atenolol, which is also known as tenormin, or metoprolol, which is also known as Lopressor. And those might be a couple of cardiac meds that you've actually given in the past before. The patient is to report any time that they develop chest pain, shortness of breath, funny feelings within the chest. If the nurse that's in on the cardiac stress test notes any arrhythmias on the monitor, she needs to let the physician know. That nurse would need to let the physician or who's ever ordering the test know, or any episodes of ST depression, which could actually show that there's some injury being occurring within the heart and that type of a thing. Other tests, as far as diagnostic testing that will be done for patients that have cardiac disorders, one would include a lipid profile. And 3 types of lipids that you've all heard of before that are usually considered part of the lipid panel would be cholesterol, triglycerides, phospholipids, and those types of things. And listed on the screen there are the desirable levels that they would like to be kept at. Usually cholesterol, the desired level is to keep that under 200. Obviously, the lower, the better. Triglycerides, I've even seen that in some lab sources listed as low as to keep it under 150 as a goal. And lipoproteins, when we look at your LDL and HDL types of lipoproteins, remember the LDL are considered your lousy lipids and your HDLs are your happy lipids. So you would rather have more HDL on board than LDL. So I always remember it by you want to keep your lousy lipids low and you'd rather keep your happy lipids high. And that would be some goals to try and be in a better physical status with those LDLs and HDLs. The reason why the LDLs are the bad or lousy lipids is because they have the greatest correlation with coronary artery disease. They actually produce arterial endothelial injury. This can progress to atherosclerotic plaques and eventually to ischemic heart disease. Whereas your HDL is more of a cardioprotective type of a lipoprotein, and these actually carry cholesterol away from the tissues and provide some protection against coronary heart disease. Obviously, anything that's those lifestyle factors we talked about on the first slide, such as smoking, obesity, diabetes, inactivity, those all decrease the HDLs, which are the ones that you want to have more of on board. A couple other lab tests that you will see ordered on your cardiac patients may include homocysteine and also C-reactive protein. Homocysteine is actually an amino acid, and this is one that contributes to the development of endothelial dysfunction and can lead to atherosclerosis, mortality, and morbidity. What it does is it alters coagulation. It actually activates an inflammatory response and then makes the endothelial lining more susceptible to atherosclerosis and different things like that. Actually makes the blood clot easier than it should, so leads to problems there. The blood test is just simply drawn for the patient, and typically optimal is to have a level under 12 millimoles per liter, and anything greater than 15 is typically looked at as a potential risk factor for that client. C-reactive protein is a lab test that actually just measures inflammation, and it can look at increased levels of it, may predict the patient is at a higher risk for coronary heart disease and those types of things. So they have done some studies and have found that when the C-reactive protein is elevated, the risk for atherosclerosis is actually elevated by 3 to 6 times that of a normal person when the patient has a C-reactive protein that's on the higher level. So depending on the source that you're using for your lab book, typically C-reactive protein normal is considered less than 6 milligrams per liter or less than 1 milligram per deciliter. So just a little sidelight tip here too. One statistic said that 20% of patients with heart disease will have elevated homocysteine levels, so can be an indicator. Cardiac biomarkers, or sometimes referred to as cardiac enzymes, are something that it's a lab test that's actually going to be drawn on patients where they are suspecting that that patient has had some sort of a cardiac injury. So maybe they're suspecting a heart attack, or the patient came in with angina and chest pain symptoms, and they're trying to rule out if that patient has indeed had a heart attack or a myocardial infarction or not. So these are actually proteins that are released from necrotic heart muscle. So remember, once a patient has a true myocardial infarction, that means that they've had some death of cardiac tissue or heart tissue. For those patients that have massive MIs, they may have a large amount of the heart muscle that's actually been affected and becomes necrotic and doesn't work anymore. And remember, heart muscle does not regenerate as some of the other muscles that are in your body and those types of things. So our goal with cardiac patients is always going to be to try to catch things quickly to try and prevent those patients from having further heart damage and those kinds of things. But at any rate, back to the cardiac enzymes, these are released when a patient does have a true myocardial infarction, because that means that there's been cell death and injury within the heart. And these are proteins or enzymes that then get released by the heart when that particular event happens. So CK is a general enzyme called creatinine kinase, and this is also found in cardiac, skeletal, and brain tissue. So what we have to do then is the lab test has to be drawn. That's an overall enzyme marker, the CK, but then also another lab test that would be drawn, it can be run from the same lab draw, would be called a CKMB, which is a very cardio-specific type of an enzyme. It's the isoenzyme for CK, and MB just stands for myobands, which means heart. So they would look, particularly the physician looking to diagnose a patient with a heart problem, would look to see if the isoenzymes are elevated on that particular client, because that can be a better indicator if there's been heart damage and those types of things. So there's actually a CKMM that will be elevated. It stands for muscle, if there's muscle damage in skeletal muscles, and there's a CKBB, which actually would be elevated if there's brain problems. So the one that would be focused on for our cardiac patients, obviously, then is the CKMB. Probably even a better test than the creatinine kinase lab test, though, would be to draw a troponin level on the clients. This is going to be the most specific biomarker for the patients that they're ruling out a possible myocardial infarction. Normal values, depending on the lab source that you use, but they're typically listed at around 0 to 0.2 microgram per deciliter. And the nice thing about troponin is it elevates rather quickly when that patient has had symptoms of chest pain with a possible MI. So if that patient has a true MI going on, you'll start to see troponin levels rise usually within about 2 to 4 hours. They'll peak at about 24 to 36 hours, and then those levels will remain elevated for up to 7 days. This is a really nice thing because think of that patient that's shoveling snow on Friday, doesn't go into the physician until Monday because they're putting off the chest pain as being just indigestion or that type of a thing. The physician can go ahead and order a troponin level, and if that patient has had true heart damage, then that troponin level will still be elevated if that patient goes into the physician 3 days later. This is a very cardio-specific test. It's about 99% specific for heart muscle damage, so it's probably your gold standard for patients that's run for patients where they suspect that they've had a myocardial infarction. Myoglobin is a test that can also be run on cardiac patients if they suspect an MI. It's not as good of a diagnostic test for a MI, but it's a good rule-out type of a test. Myoglobin, the advantage of that is it elevates within only about an hour. It peaks in about 4 to 6 hours, and then the levels will stabilize in about 24 to 36 hours. So this is a good one that's drawn a lot of times in an ER. You have a patient that comes in with signs and symptoms of chest pain. As we all know, just because a patient comes in with chest pain doesn't automatically mean they're having a heart attack. So this would be a good lab test. You can get the results back very quickly, and it can help to decide that it's looking like this patient probably is not having a heart attack because it's not elevated. But to truly diagnose if that patient has or has not had an MI, probably a better lab test to go with would be the troponin because, like I said, it's 99% specific for cardiac muscle in that type of a thing. Other tests patients with potential cardiac problems and disorders may have ordered would be a BUN creatinine. We're going to talk a little bit about patients having angioplasty and things like that done. Obviously, if they're going to be getting certain types of isotopes and dyes through a lot of these scans, we want to make sure that their kidneys are functioning correctly before we start giving them a lot of things that need to be excreted by the kidneys. CBC can actually look at a white cell count elevation, which sometimes we do see on our MI patients. That's quite common. We'd like to do coagulation studies and look at the patient's PT, INR, and PTT levels, and also electrolytes, particularly the one that you'd pay a close attention to with a heart patient would obviously be the potassium level. We can also look at heart valves and dysfunction of the heart valves. Probably one of the simplest methods to do that is by echocardiogram. It's just going to look at the heart size, shape, valve function, can look at ejection fraction and also wall motion of the heart. So reminder on what ejection fraction is, it's just the percentage of blood that's pumped out of a ventricle with every heartbeat during the systolic motion of the heart, or in other words, during contraction of the heart. So normal values of ejection fractions are, depending on the source you look at, but usually somewhere between 50 to 60 up to 70%. So obviously if a patient comes in with a 30% ejection fraction, we know that they've got significant cardiac problems going on. There's types that we can break down, 2D Dopplers and different things like that also. And we can look at cardiac Dopplers that can look at speed and direction of the blood flow. So for those patients that maybe they're not getting a good echocardiogram picture on that particular patient's heart, maybe because that patient, one example might be if the patient is extremely obese, that type of a thing, or because of other particular physical problems that patient may have. Another option might be called a TEE, or a transesophageal echocardiogram. This is actually a probe that the patient is given an anesthetic, and this probe is inserted where the patient would then swallow it, and it would put down to look at into the esophagus, and it actually will give then more of an inside view of what's going on with the heart. So with this one, the patient, since they do need to have that electrode placed in there and in the esophagus and those types of things, One of the nursing care things would obviously to monitor that patient while they're having conscious sedation being done. They're going to need IV access. They're going to be put on oxygen, and they need to have continuous oxygen monitoring and O2 sats being done while they're having this particular test done. And then afterwards, the patient's going to be NPO until the nurse is quite sure that the gag reflex has returned, that the patient is awake and alert enough to be able to swallow, and that type of a thing. So refer to your textbook. The page is listed under the speaker notes to give you a little bit further more information on what a TEE is. This is another diagnostic tool for clients suspected of having cardiac disease, cardiac caths. It's a very common thing that's done in the United States, and it can give detailed information about the structures and function of the cardiac chambers, the valves, the coronary arteries, and all those kinds of things. So patients typically will have both a right and a left cardiac cath done. They're usually done at the same time. But when they do them, the patients they're accessed differently. To do a right cardiac cath, this is actually through a venous route. So they need venous access. Probably one of the most typical places that they're going to access for a cardiac cath is going to be either through brachial area or femoral area is typically, probably femoral is the most common area that's used for the cardiac caths. And what they can do with a right-sided cardiac cath is go in and look at blood samples and pressure readings taken within the right side of the heart. So also another one that may be used is internal jugular vein and that type of a thing. That can look at O2 sats. It can look at pulmonary artery pressures and all sorts of things like that. The left-sided cardiac cath is actually done via the arterial route. So with this one, we think of femoral artery as a very common area, that this is where the actual catheter is inserted and then scanned up to the heart. And with this one, it's almost like it's put in retrograde in order to get a good visual of the heart. So in other words, it may be started in the femoral artery and then threaded up through the aorta to the left ventricle to the mitral valves and aortic valves to take a look at what's going on within the heart that way. And this can actually look at coronary arteries and look at amount of ischemia or narrowing and that type of a thing that's seen in coronary arteries and those types of a thing. Some pre-op nursing care for patients undergoing a cardiac cath. Obviously, they're going to do this under fluoroscopy. There's going to be a contrast agent that's going to be injected, and then under fluoroscope, it will be visualized if that patient does have any narrowing or ischemia within the coronary arteries and that type of a thing. So because they are getting a contrast dye, the patient needs to be checked for allergies to the dye. Patient needs to make sure they don't have bleeding disorders. So coag studies are going to be checked before the patient had this done. They want to make sure the electrolytes are okay, the patient's renal function, so BUN and creatinine will be checked. The patient will be NPO before a cardiac cath. They will be awake, but they'll be sedated. So they may have conscious sedation with Versed or something like that. And they need to let the patient know that they may experience a flushing, pounding sensation when the dye is actually injected. So let them know that's nothing to be worried about. But they are to report if the patient, has arrhythmias, actual chest pain, and different things like that. So remember, if that patient has allergies to dye, they're typically also allergic to iodine and shellfish. So that's typically, as nurses, the question that we ask the patient on the pre-op medical form and those types of things when we're looking for that. So I do have a friend that's a nurse in a cardiac cath lab, and I asked her what they do for patients that have a possible allergy to dye, but they're not. The patient isn't sure if they've had an true allergic reaction ever before to a dye. And she told me typically what's done is that patient's given steroids and Benadryl for a couple days before the procedure, and then they go ahead and see how the patient reacts to the dye. And she said that's typically the scenario that they see done. Post-op, after the patient's had a cardiac cath done, it's going to be important, obviously, since they've accessed a femoral artery or a large arterial site in order to do this, that they're going to have vascular checks, look for post-procedure, look to make sure that that patient has good circulation down in the legs, if the femoral route was used, and that type of a thing. So pulse checks are going to be very important, especially on the site. Like if it was done on the right femoral area, then check the pedal pulse, particularly in the right foot against the left foot. Make sure that they're equal, they're strong. Color is good in both feet. Make sure that the patient has good sensation, and all those types of things. The other thing that's going to be done is monitoring fluid status, INO, making sure that that patient's kidneys are able to handle that dye being excreted and that the INO is balanced and those types of things. Patients are kept on bed rest for a certain amount of time after this, and typically vital signs are checked about every 15 minutes for an hour and then about every 30 minutes for 3 hours until that patient's stable, to make sure that the patient's okay. The nice thing is that nowadays hemostatic plugs are used in the arterial access site, so they're like a collagen plug is a good way to describe them. Angioseal is a common one that's used, and this is actually put in as the catheter is taken out, and this actually will stay within the system. It takes about 90 days for that to dissolve. The nice thing about that is that patients don't have to stay on bed rest quite as long after they've had a cardiac cath. I can remember taking care of patients before those were developed, the collagen seals, and the patients would be kept on strict bed rest, kept in alignment with sandbag, pressure dressings and all these kinds of things over the femoral area to keep them, from not having bleeding problems and things like that. And they had to be kept on strict bed rest for about 8 to 10 hours after having that procedure done. So the development of the collagen plugs was a wonderful thing for patients. This is a picture of a cardiac cath lab and what that would typically look like for a patient. So part of the pre-op teaching is also to let the patient see a videotape of what it's like, just as far as equipment in the room, so that the patient's not overwhelmed when they're taken by what it looks like. And as you can see, the picture on the right side there is the fluoroscopy, where they're actually injecting the dye and then using the fluoroscope to look at and see what kind of stenosis that patient has in those coronary arteries. Another type of test that's very similar to a cardiac cath is called the EPS studies, or electrophysiology studies. And what these are, this would be a good type of a test to have for a patient. It's similar to a cardiac cath, but what happens is this will be for a patient that maybe's had a particular arrhythmia that's an intermittent type of a thing. The patient maybe complains of feeling tachycardic from time to time, real rapid heartbeat, and then feeling lightheaded, or having episodes where they feel like they're having skipped heartbeats, or whatever the particular issue is with the patient. What they will do is bring the patient into a cardiac cath setting. They will try to elicit that particular arrhythmia that the patient is having, and then they can look at it under fluoroscopy and decide the best route or the best way to fix the problem. So electrical stimulation may be used to induce the arrhythmia, and then they'll treat it they can actually treat the arrhythmia once they discover what it is, and they can decide what they need to treat that with for the patient. Sometimes patients will need an automatic defibrillator or pacemaker put in as part of the treatment modality, depending on the type of arrhythmia that they have. So that might be an option that they would have. Actually, the patient, if they are on some sort of an antiarrhythmic drug, those are stopped before this particular test, so that the cardiologist can actually try to get a good visual of what particular arrhythmia that patient has. So this would be for the patient that's having intermittent problems. They don't walk in a particular arrhythmia, but because of their signs and symptoms, this is kind of what's suspected, is the patient has something like that going on. So it's typically used for patients that maybe have symptoms of syncope, palpitations, maybe they're ventricular fibrillation survivor patients, or VTAC survivors, and those types of things. So when we talk about analysis of patients with cardiac disorders, we look at risk factors, and we look at non-modifiable and modifiable risk factors. You can probably guess as to what these are. We talked about lifestyle factors on the first slide that can lead to patients being more at risk for cardiac disorders. But when we look at modifiable things, things that the patient can actually change within their lifestyle habit would be considered in this particular column. So smoking, sedentary lifestyle, obesity, hypertension, stress, cholesterol levels based upon poor diet, maybe diabetics that are in not good blood sugar control, type A personality patients that maybe could benefit from some biofeedback techniques. Those types of things would be considered modifiable. Non-modifiable types of risk factors would be the patient that's perhaps just by gender. We talked about men are more at risk for cardiac disease than women until women get to be postmenopausal. Increased age could be related to family history and genetics, and also race and that type of a thing. If we look at coronary artery disease, it probably affects about 1.5 million people per year, and approximately 500,000 people per year die from having heart attacks or myocardial infarctions. So it's definitely a significant problem in our society. This is a cute little slide that talks about these obesity studies have me really worried, so I'm going to drive next door for a checkup. So that kind of says a lot in that slide. Physical assessment of our patients that have cardiac disease, some signs and symptoms that as nurses we're going to look for are: one, is that patient exhibiting any dyspnea, or does that patient have chest pain? And if they do, some things that we want to ask them are, first of all, where exactly is that chest pain? Is it substernal? Is it across the whole chest wall? What's the quality of the chest pain? Is it a squeezing chest pain? Is it constricting? Does it feel like an elephant sitting on your chest? When I worked in cardiac intensive care, a lot of patients that came in having an MI, that's exactly how they described their pain in their chest. They would say, it just feels like I have an elephant sitting on my chest. And of course, their color would be horrible. They would be diaphoretic, and you could tell that patient was in excruciating pain. But it would be important to note, is the quality of the chest pain more of a burning, aching? Is it constant? Those types of things. Sometimes patients don't know if it's a heart problem that they're having or if it's an upper GI problem with GERD or different things like that that's going on to cause it. And that's why we do labs and all the diagnostic tests to rule out and decide which particular problem is the heart that the patient has. The other thing that as a nurse we would want to do as far as checking out signs and symptoms and getting a little bit more information is to find out, does that chest pain radiate anywhere? Particular areas that are very common for chest pain to radiate for those patients that are having a heart attack is if it radiates up the neck or down the left arm or to the shoulders or the jaw. That's a very common thing. And so with those patients, we would want to make sure that that's documented and that we're giving them some quick relief of that pain. Because if they're truly having that much pain, it's causing cardiac damage. And remember, that's one of our goals, to try and keep that patient from developing further necrotic areas within the heart. So we would want to give them some quick relief. And typically the things that we do with that, nitroglycerin and morphine, are probably two of our hallmark meds that we give for patients where we're thinking they're experiencing an MI. The other thing that would be looked at is the severity of the symptoms, and does that patient have associated symptoms such as pallor, diaphoresis, dyspnea, tachycardia, very anxious, fearful, that type of a thing, and also the timing of it. Did it happen with exercise? Did it happen at rest? Did it happen with the patient out being in cold weather? Those types of things. Other types of physical assessment things to look at is the patient, did they also have associated syncopal episodes? In other words, did they feel real lightheaded and dizzy with it? This could be caused by cerebral hypoxia if the patient does indeed have a cardiovascular problem going on. Could also be from an arrhythmia that they're having syncope. For example, if they're in a tachycardic type of situation or in one of the heart blocks or different things like that. Also, if that patient has palpitations, so you'd want to note if that patient has rapid heart rates, skipped beats, all those types of things, and listed on the speaker notes are many, many different causes of palpitations. And those patients that are exhibiting any early symptoms of congestive heart failure, you may notice edema on those patients. So look for lower extremity edema and those types of things. And your speaker notes talk about good ways to check for edema. We alluded to this a little bit earlier. Are there any gender differences in cardiac disease between men and women? Like we said, once women hit postmenopause, because they don't have the estrogen on board anymore, estrogen tends to be very cardioprotective, and because that's not on board, that puts men and women pretty much in equal ratings as far as the risks of cardiovascular disease and those types of things. So typically it's said after age 60, the risks of vascular disease or atherosclerotic disease are equal, men and women. The other thing is remember that menopause elevates the lousy lipids, the LDL, and it actually decreases HDL lipid levels. So that's an issue with postmenopausal women also. About 15% of all men and women will actually have a silent ischemia, or sometimes it'll be called an asymptomatic MI, where they actually will have heart damage without having any chest pain with it. And a lot of times this can be attributed to sometimes that patient may also have a comorbid position of diabetes or things like that, where they maybe have some neuropathy going on, where they're not having the sensory stimulation the same as a patient that did not have like a diabetic problem going on or those kinds of things. And one particular article that I read had statistics in it that showed more women die in the United States from coronary heart disease than women that die from breast cancer. So about 1 in every 5 women in the U.S. will actually develop coronary heart disease. So I think there's been more and more of a public awareness through commercials and through the literature in lay magazines and those types of things to try and alert women that it's not just a man's disease. It definitely is something that affects women as well as men. Other symptoms to assess on clients with cardiovascular disease might be an altered blood pressure, altered pulse. We're going to look at the rhythm and character of the pulse, and abnormal heart sounds that patient may also have. So the patient may have an S3, an S4, murmurs, and all those types of things. So with those different abnormal types of heart sounds, they can be very indicative that the patient has some sort of an underlying problem going on. Remember, the S1 is the lub sound that you hear with just a typical lub-dub, your S1, S2 sounds. Remember, S1 is noted loudest at the mitral tricuspid area, whereas S2 is loudest at the aortic pulmonic area. And then an S3 is considered an abnormal find in patients over about the age of 25 or 30. Actually, in young kids, we don't get too worried about S3s because we hear them quite a bit. But an S3 would be abnormal. It's been attributed to sounding like Kentucky. So if you listen to an S3 on a patient, you're actually picking up a third heart sounds, and it'll sound like Kentucky, 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 that type of a thing as you're listening to that patient. And indicates a ventricular gallop, so it's usually indicating some sort of a heart failure problem, as you've got a ventricle that's trying to fill rapidly, that it's already partially filled because it hasn't had a good contraction, and so there's still blood left in that ventricle that should have already left, and that's why you're hearing that extra swishing or that extra S3 heart sound and that type of a thing. And S4 is always a pathological finding. This is an atrial gallop, and this is indicative of sounds heard during atrial contraction as the blood enters a non-compliant ventricle. So this is usually heard best at the right sternal border, and it sounds like Tennessee. In the speaker notes, I put a website that I think does a really nice job. It's the UCLA medical website, and you can go on and you can click on abnormal heart and lung sounds. So if you've never heard an S3 on a patient or an S4 on a patient, or you've never heard what wheezes or rails or heart murmurs or different things like that sound like, go on that website and listen to it. I think it does a very good job of indicating what those sounds actually sound like. Patients that have cardiac problems, you might also see neck vein distension on those patients. And remember with that, the patient is elevated 30 to 45 degrees when we're looking for neck vein distension. A lot of patients, if you lay them flat in bed, they're going to have neck vein distension, but when you elevate that, elevate the patient, that neck vein distension should go away. So patients that are elevated and still have neck vein distension shows you that they have a problem with the heart and typically indicates some sort of heart failure. Patients may have altered capillary refill. It could be central, where you would see it in the lips, the buccal mucosa, under the tongue, that type of a thing. That's usually a later sign of hypoxia. Or they could have peripheral cyanosis, is what we look at with the earlobes, the tip of the nose, the fingernail pressure, and that type of a thing. This is just another indication of S3 and S4 heart sounds. So just gives you a little bit of depiction where in the cardiac cycle that you would hear the S3. So if you look on there, you can see that the S3 occurs immediately following the S2, which would be the dub part. So it would be lub dub, and then you'd hear the S3 sound. Whereas if you look over to the right in S4, since it is an atrial problem, you're going to hear that immediately before you would hear the S1. So just gives you a little picture of that. Other symptoms to assess on our cardiac patients would be if they're pale, indicating decreased blood flow, if they have altered renal function and poor I&O balance and those types of things. Could be that there's a problem with the renin-angiotensin system due to decreased renal blood flow, and it's throwing off their I&O and that type of a thing. You might also see altered GI function if that patient has right-sided heart failure, or altered neurological function, as we talked about earlier, if that patient has poor perfusion going through the heart and that type of a thing. Patient may have altered GI function also if they have a hepatomegaly due to right-sided heart failure and poor circulation and those types of things. And then the patient obviously may feel fatigued due to just the poor cardiac output if they do have some sort of a heart problem going on. Common medications that are used for coronary artery disease are listed on this slide, so please review your book and know those medications. It's very important as you study all this information on clients to be able to adequately take care of a cardiac patient. You need to know what medications they're on. You need to know what would be the side effects of that med, what would be that med be used for, and all those types of things. Are there any contraindications if a particular medicine is given that that patient can't be on another med, or different things like that. So those would be all things that you want to look at as you look through that list of medications. And as you study for the exams for this class, put yourselves in the shoes of a nurse and think of, if you had to take care of a patient with a certain disorder, what do you need to know to do a good job to take care of that patient? You would need to know what meds they're on, why they're given, those types of things. You would need to know what laboratory and diagnostic tests that patient might particularly have done. So if that patient had questions on what can I expect from this, or what's this going to show, you would need to know what interventions are typically done for a patient with that particular disorder, and what kinds of things you need to assess as a nurse for a patient with a particular disorder. So as you study all this information, which I realize in the coronary area is a lot of information, think those questions in your head. If I'm standing in the shoes of a nurse taking care of a heart patient, what kinds of things do I need to be aware of, and do I need to know to take care of this patient adequately and to do a good job? Another thing that we need to do as part of education for our clients is to let them know that yes, it is important to watch what they eat. Obviously, the food that they eat has a direct effect on their cholesterol and triglyceride levels. Cardiac patients are typically put on a no added salt, sometimes as low as a 1 to a 2 gram sodium diet, which means they're only getting 1,000 to 2,000 milligrams per day of salt in their diet. And just going through my pantry to look at some things that the salt values of different things, it's kind of amazing when you look at the quantities of salt that are in things that you think are pretty healthy foods. For example, milk, actually 1 cup has 120 milligrams. So that patient could be having multiple dairy sources per day and not even realize that they've already hit their 1,000 milligram mark of their allotment of sodium for the day. 11 pretzels has about 330 milligrams of salt in it. And as you can see, anything that's canned or frozen has large amounts of salt in it as a preservative. So that's why you see the things in the speaker notes listed with so much sodium in them. So activity guidelines, unless it's contraindicated, the patients are encouraged to exercise to meet their target heart rate. And the latest guidelines are that people are really supposed to try and exercise 30 minutes a day, 5 to 6 times a day. So that is the goal. Interventions for clients with cardiac needs. We're going to look at some of the things that would be done for clients, such as balloon angioplasty and things like that if they are suspected of having a coronary problem. The first slide here looks at percutaneous transluminal coronary angioplasty. Sometimes you'll just hear it referred to as PTCA. A patient that's having this done, the pre-op care is going to be similar for a cardiac cath, and the post-op care is also going to be similar to a patient that's just had a cardiac cath done. It usually can reduce the vessel obstruction in the coronary arteries by less than 50% or so. And what they actually will do is go ahead and place a catheter into that actual coronary artery, and on the end of that catheter is a balloon that can then be inflated when they get to, it's done under fluoroscopy. So when it gets to the point of the narrowing within the coronary artery, that balloon can be inflated, which can then open that artery up, compress the plaque, and that type of a thing. So typically what's done then is a stent, either a metal or a medication-coated stent, is put in over the cardiac cath and left in place within the coronary artery, and that will keep the vessel open then for a longer period of time. So the problem is with this, about 4 out of every 10 stents will end up re-stenosing or reclogging back up again. So that's the problem. It's not like having this done once. If there's no lifestyle factors that are changed, the patient's going to obviously redevelop plaque again and redevelop the same stenosis. So in order to qualify under insurance requirements, the patient also needs to have about a 70% vessel occlusion to qualify to have the procedure done. In the United States, there's about 1 million done per year. The patient is put on anticoagulation medication, and the patient is also put on medications, the glycoprotein meds that will help for antiplatelets and those types of things. This is an example of an angiogram scan. So you can see that the patient pre-angioplasty had the stenosis to the left, and then after the angioplasty, you can see what a huge difference that made in the coronary artery for that particular patient. The intravascular stents that are put in, as we talked about, will help to maintain vessel damage. There's a balloon that's used to inflate the vessel, and the stent is then left in, and then the endothelial cells will grow to produce a smooth lining on the inside of that. So they actually, by putting a stent in place within the coronary artery, it decreases the incidence of restenosis up to about 1/3 or so. And like I said, many of the stents that they're putting in now, they're actually putting in stents that are medication coated that will even keep the stenosis from happening for a longer period of time in those types of things. Complications of having this procedure done, there's the risk of a hematoma, there's a risk of an embolism, there's always the risk of an aneurysm. The patient could have a reaction to the contrast dye that's used. They could develop a dysrhythmia because you are putting this catheter right into the coronary arteries. There's the risk of vessel perforation. We talked about the statistics on how many will actually restenose again. So those are all issues. If the patient is not a candidate for angioplasty to open up that coronary artery due to a medical condition, or the physician just feels that a CABG procedure would be a better option for that patient, then that might be the alternative that that patient has to go through to fix the coronary artery occlusion. So this is where the graft is done, the coronary artery bypass graft surgery actually bypasses the obstruction in a coronary artery. And so what it does is they reanastomose another artery or vein and bypass the part of the obstruction altogether. So if you look in your book, they give a great description on CABG procedure and that type of a thing. To have this done, the patient also needs to have a 70% occlusion to qualify. Typically is about a 3 to 5 day hospital stay. And there is also, if the patient would qualify, a potential for what they call a minimally invasive direct CABG procedure, which they can make a smaller incision, and the patient has a much quicker recovery period. They're usually only in for 2 to 3 days post-op. This slide depicts typically the most two common arteries or veins that are used for the grafting. The mammary artery, the nice thing about that is if the patient's mammary artery can be used, about 90% of those will remain patent for about 10 years after the surgery. However, there are some restrictions. The patient can't be obese. The patient can't have extensive diabetes, those types of things. The saphenous vein, unfortunately, usually the stats that I was able to find on it, it tends to close or restenose. About 40 to 50% of them will restenose or reclose within about 2 years after having that done. So obviously that's going to be very dependent on each patient's situation and those types of things. But so obviously if the patient had a choice and could pick between mammary or saphenous, I think the cardiologist would go with mammary if the patient's a good candidate for that. This is just a diagram of the CABG procedure and how it actually just does bypass the area of stenosis, and you can see how that fits in there. This slide really focuses more on post-op nursing care for a CABG procedure than pre-op. So pre-op would essentially just be teaching. The patients are shown a videotape of what to expect. The family is taught what to expect post-CABG as part of the pre-op teaching and all that type of a thing. Post-operatively, the patient's going to be in a cardiac recovery room. The heart is going to be irritable for a little bit after this particular surgery, so the patient's going to be closely monitored for arrhythmias and those types of things. They're going to have epicardial pacer wires attached and available to need in case they would need emergency pacing done. They're going to have continuous oxygen saturations done. Remember, if the patient had the traditional CABG procedure done, they've had their sternum completely opened up. So those patients are going to be also in a lot of pain. So they're going to have chest tubes, incisional care issues. They're going to be on a ventilator for an amount of time after the surgery. They don't keep them laying around for long, though, as you'll find if you're in an area where CABG procedures are done on your clients. Those patients are gotten up, they're getting moving, and extubated very, very quickly because obviously they're going home within about 3 to 5 days after having this procedure done. So patients, to monitor their fluid status, are going to be on daily weights, accurate I's and O's, pain management, trying to get them up and moving as soon as possible. They may need EPC cuffs to help decrease the risk for deep vein thrombosis and those types of things. And then they're going to need the use of incentive spirometers and to cough and deep breathe to try and keep the lungs expanded and those types of things. So please refer to your book for further information on the post-op care for patients that have had a CABG procedure. Patients that have had a CABG procedure will be on a bypass machine. This is just giving an example of what cardiac bypass might look like as that patient's having that done. And this shows a diagram of a patient in a post-CABG procedure. So as you can see, the patient has tubes and wires everywhere. So it's important that the family and the patient knows preoperatively what to expect so that they're not overwhelmed when they walk in to visit that patient after having the particular surgery done, since that's overwhelming to see all those different wires and lines on a patient if you're not expecting it. So that is part of the education that the clients and the families are given so that they know what the expectations are and what to expect after the surgery.